If you've been in touch with your GP recently, you'll most likely have done it via your computer, perhaps writing details of your worries, answering a questionnaire, providing photos of, well, that rash or maybe that verruca that your child developed. It's all thanks to our next guest, Dr. Murray Ellender. He's a GP who has literally transformed the way that healthcare is being handled in the UK. As CEO and co-founder of eConsult, he's been trying to cut wasted clinician and patient time by using technology. It's key. eConsult is used by more than 3,500 GP practices. That's more than any other of these systems in the UK. Its sister platform as well, eTriage, is currently used by 9 NHS urgent and emergency care departments. So this will all hopefully improve safety and therefore potentially meet our greatest challenge right now, which is to help save more lives. But is everyone on board with that? Are there another few issues that need to be considered? Let's dig deeper into what is this new world. And if you're going to have any questions, of course, please put them in this session's Q&A tab, and I'm going to get to them at the panel after we've heard from Dr. Murray Ellender.
Thank you very much for the introduction, and thank you also for inviting me to speak today. It's been a real honour to be asked. I've actually got some slides which I'm going to share with you, so bear with me while I just share my screen, and hoping that's working and you can see the screen, but I'm sure someone will let me know if you can't. So Claire, thank you very much for the intro. I am Murray Ellender. I'm a GP in London, Chief Executive of eConsult, and I'm going to tell you today a bit about eConsult and the journey that we've been on and how we got here, really. I've got some slides, they're mostly pictures, but effectively I'm going to tell you a story, and a story about what we built and why we built it. So how it all started? Well, as I said, I'm a GP in London, part of an organisation called the Hurley, and I guess a few years ago, we were slightly frustrated that the system for accessing your GP was as it had been forever. As in, if you wanted an appointment, you had to get on the phone at 8 o'clock in the morning, queue often for 30, 40 minutes to get through, and then you'd be offered a face-to-face appointment with a doctor a week or two further down the line. And it seemed a fairly inefficient way of running general practice. We knew that digital held the key to help us. Initially started off doing video consultations like everyone kind of naturally thinks, okay, I'll Skype my doctor, but actually pretty soon found that video is fine, but it's still a synchronous interaction. You still need 10 minutes of a doctor and 10 minutes of a patient at the same time. The other problem with video is that the broadband in most practices is rubbish. As soon as you've got 2 or 3 doctors on a call, it'll all grind to a halt. And you don't want to, if you've only got 10 minutes, you don't want to waste the first 2 minutes trying to connect to your doctor. So we came up with a different idea, which is gather the story from the patient up front, ask them the questions that the GP would normally ask them up front, and put that in front of their own doctor, their doctor who has their medical record. And we've been growing that ever since. So I'll tell you a little bit about the journey and what it is, and for those of you that have never come across it before. So effectively, if you're a patient or a parent or a carer, your access point is the GP surgery website generally. We're also available within the NHS app. And so through there, you can access the system, and you go on with whatever condition you want to see your GP about. It will then ask you a series of questions about that condition. We can also signpost to other local services, so route you through to excellent self-care advice or the local pharmacy. But assuming that you actually think you need the GP, we'll take that story, so ask all the questions that you'd normally be asked by your GP. We'll put that in front of your GP, and I say GP, but more often than not now, we can route that to a much better person within the practice to deal with it. So it might be a pharmacist for a medication query, or a physiotherapist for a musculoskeletal. And then what often happens is that we can close that consultation down as a clinician, as a doctor, without bringing you into the building, which is good for patients, but also good for the system and the wider service. Now, we've been doing this for a few years, and what we found pre-COVID was that you could close about 70% of the eConsults down without bringing the patient into the building. So that's maybe a message back to the patient, your prescription's available to effect at a pharmacy. 40% of the time, you maybe have to ring the patient up, tell them your plan. And about clearly 30% of the time you'd be bringing the patient into the building because they need to be seen. Now, COVID changed all of that, and I'll come on to the kind of COVID effect shortly, but we're now seeing up to kind of 90% remote closure rates. So if you're gathering enough information from the patient up front, you can often manage a patient without them having to take time off work to come in and see the GP. Clearly, always going to be opportunities where you have to see the patient. You may need to examine their abdomen, for example, or do some tests. So actually, there's always going to be face-to-face. And I suspect what will happen now as we move out of the COVID era, we'll start to swing back a bit towards the more face-to-faces. Now, effectively, what we gather is a structured story from the patient. Okay, so to the patient, it may feel like we're asking quite a lot of questions up front. And for anyone who's done it, that's often the complaint from patients is, why are you asking me all these questions? But what we're doing is we're gathering all that information that your GP would normally gather. So it might be a series of kind of open questions. It might be pictures. We can pull pictures through of that rash. But all the time, we're gathering that story to put in front of your doctor and maximizing their chance of being able to close it remotely. We've also got lots and lots of safety built into the platform. So there's these things called red flags within the system that will allow us to detect if your symptom is a bit more urgent and route you through to something that's more appropriate. Because actually, you might be doing this on a Saturday afternoon when your GP surgery is closed. And actually, how do you know as a patient that those symptoms are more urgent? So we can route those cases away from the surgery and into a safer place of care. So effectively, when seeing the doctor, what we've created is an asynchronous interaction with your GP. Okay, so everyone's used to a synchronous interaction, phone, face-to-face, and that's still the majority of interactions. But actually, this new way of interacting with your doctor is growing. Okay, and actually, we're already seeing over 1.2 million online consultations a month across our practices, which is about 10% of all appointments. So actually, there's still a lot of room for growth in this way of consulting, I've got no doubt at all. So on to growth. So we as a software supplier have grown over the last 7 years, and it's been a long journey. And you can kind of see, this is the kind of graph that shows our slow from kind of that initial 10 practices down in London, how we've slowly scaled this platform out across the NHS. And initially, when we started selling the platform to surgeries, it would be kind of word of mouth, organic growth. The NHS put some funding behind online consultation in about 2016. This being the NHS, it then took about a year for that funding to arrive. But when it did, you can start to see the uptick in usage. And then clearly, a year ago, things changed dramatically. And the tools that are used by GPs now to manage their patients remotely suddenly became incredibly useful. So NHS England said, look, actually, every practice should be using this sort of technology. So there's us, there's plenty of other suppliers that do this too. This is just the growth in the number of consultations. So I'm not going to just stand here and show you a whole series of exponential curves, but it's interesting to see that if you look back a year ago, we were doing about 100,000 consults a month through the platform. We're now doing over 1.2 million. So there's a lot of learning that goes along with that. We are learning and developing and iterating constantly. And again, just to make the point, if you look back through the years, this is the monthly data. So there's just a huge amount of change. The health technology transformation that we've been working on for the last 5 or 6 years has finally happened. We're updating the platform and now kind of improving the journey in response to feedback both from patients and from practices. So improving that patient journey, making it shorter, slicker, easier to find the condition that you're consulting with. The other, because online consultation has now become a thing, the clinical system suppliers, so that the systems that are used within your GP surgery are waking up to this, and they're actually now opening up the interoperability that we've been asking for many years. So this means that actually I won't need to ask a patient every time they consult about their smoking status or what medication they're on, because I should be able to read that from the patient's record sooner. So that will improve the patient journey. And we're also doing lots of work behind the scenes to improve the experience for the clinician, the doctors, the nurses in practice, to help them in managing this new way of working. So general practice is an incredibly busy place to be. And actually you want this process in the GP side of things to be really slick. So we're doing lots of work on that at the moment. Now, I've got a great affiliation with the Northeast. It was one of my first sales pitches up in Sunderland back in 2015. So I was moving from being a doctor to being running a technology business, and came up to Sunderland and did a sales pitch. So it was a great kind of start to my sales career. And we've actually got a really good relationship up there. We've got 320 practices across the 11 CCGs in the Northeast using the platform. This is the dashboard of usage by CCG, and I'm sure those on the call who might like more competitive side might like to look at who's doing the best, but bear in mind that actually some CCGs are bigger than others. So the other point here is looks like there's a big drop off at the end, but that's only because we're part way through the month of June. Now we share lots of data with the practices that helps them understand how patients are using the platform. So we now can tell what we all knew before as GPs, that Monday is the busiest day in practice. So those dark blue lines on that graph are the Mondays. We still get lots of people consulting with their GP kind of at the weekends, and that presents its own problems. But actually, as a patient, it's good that you can access your GP. You don't have to kind of be compartmentalized into this period between 8 and 6:30. The age range is, don't assume this is just the young tech savvy. We've got age range users across the age groups. And we also collect lots of data about what sort of condition patients are consulting for. So there's a huge tail of what conditions patients consult for. And the other thing that we gather is patient feedback. So every patient who uses the platform is voluntarily asked if they want to complete a survey. And actually what we find is that patients are overall incredibly satisfied with using this system. It's not for everything, but for certain things, it's a great way to access your GP. And the other thing in the Northeast is we're working very closely with Opencast and harnessing some of the talent in the region. And we've got some fantastic developers now who've joined our team. We're investing in our development engineering team, and we've got some great team members from Opencast who now work for us. So it's fantastic. So the final couple of slides I'll end on, I kind of, well, what next? So I think apart from the kind of improvements that we're making all the time to the GP platform, we're now also starting to apply the same principle in other settings, as Charlie referenced in her intro. So why not transform the way that the journey happens when you walk into an A&E, or even when you go and see a specialist? So these are the next areas that we're working on. And we've already put this system into a number of A&E's urgent treatment centers. So here it's the same idea. We're gathering the story from the patient in their time, not in the clinician's time, but it happens via a whole bank of iPads. So we've turned the waiting room into like an Apple store. You walk in, instead of interacting with a receptionist and then a triage nurse, you interact with an iPad. It asks you who you are, and then it asks you why you're there. And based on that information, it'll work out very quickly who the sickest people are. Don't think that we've taken the humans out of the equation. There's still receptionists, but they will be the people who will navigate patients through the journey who feel a bit uncomfortable with using an iPad. So we can automate that triage as you arrive in the A&E. We're looking at technology that will also then gather your blood oxygen levels or your pulse while you're standing at the iPad. We can then work out how sick the patients are and then put the sicker people to the top of the queue and the less sick people a bit further down the queue, and actually even identify those patients who probably shouldn't be there in the first place and redirect them back into a more appropriate place of care. So that's what we're doing in the A&E space, and seeing huge advances in kind of safety. You haven't got that long wait to be assessed up front, which makes for a much safer department. And the other bit we're working on is outpatients. So this is when you go and see a specialist. And again, why not do the same thing? Gather some information ahead of that visit so that when you see the specialist, they've got a lot of that history, that story from you up front. They can maybe order a lot of the tests and investigations that they need. And yes, they may well need to see you face to face, but when they do bring you into the hospital to be seen, they've got a lot of the information up front. So it saves lots of toing and froing back and forth from the hospital. So again, lots of advantages here. We're working in partnership with a big hospital trust at the moment to evolve and iterate this product and bring it out. And lots of opportunities there as well for things like patient-initiated follow-ups. So this is where, for example, you might have a chronic long-term condition like rheumatoid arthritis. Why just be in a cycle of 6 months every time you come in to see the specialist? Actually, we can make it that if you're fine at 6 months, you could wait to 12 months. And when your arthritis flares up, you can initiate that follow-up. So looking at some great new ways of interacting with the health system. So my last slide is just to say that, look, we're currently operating really at the door into general practice, but also starting to work in the doorway into A&E. But what we're really keen to do is to start to join these doorways up. So have a system that actually can understand when a patient presents into healthcare, what their need is. So where are they most appropriately seen? Is it the GP? Do they need more urgent care, or maybe they need specialist care? So starting to think about how we join those journeys up across a health ecosystem. So that's it now. I've reached the end of my time. I'm going to stop, but I'll leave my details up on there on screen. I'm very happy to take any questions at all. And thank you for your time.
Really fascinating. As somebody whose GP practice uses eConsult, even in the past couple of weeks with the little one, it's been interesting to see that. I'm glad somebody's told you about the list of questions. We have NHS doctors in the family who've said they're essential. You need to know if meningitis is connected to that rash. But I think there are a few things to ponder on that some delegates have put forward as Q&As. Please keep them coming. So if you click onto where there's the event tab and the session tab, if you go into the session tab and click on Q&A, that's when you can add your questions, and I'll keep an eye across those. I've got some to get to. I'm also going to bring in the rest of the panel as well. We have Mark Thompson with us, who's Director of Consulting Services at CGI. We have Dave Belshaw, Digital Transformation Director at Academic Health Science Network for the North East and North Cumbria. A mouthful, but brilliant to see you, Dave. Hi, Dave. Emma Whitenstall as well, of course, Dynamo's Health Tech Cluster Manager. And I believe Rachel Murphy is there as well, Chief Executive of Difrent. Hi everyone. Rachel, been getting an awful lot of coverage recently, as usual. And we've got Dr Murray Ellender, CEO of eConsult. I'm Charlie Charlton. I'm going to be chairing this panel for Dynamo 21. Keep your chat going as well on the socials with the hashtag Dynamo 21. Can I start with you, Murray? Because one issue that has been picked up in the medical press that I've noticed is that your service has been so successful, it's actually led to an avalanche of demand. So there's a bit of concern that the increased workload on already stressed clinicians is just going to rise. What's been your response to that?
Charlie, it's a really good point, and one that's particularly hot for practices that we deal with at the moment. I mean, I think the thing that people seem to forget is that you can't just drop technology into a practice and hope that it's going to work. You've got to think about the transformation that goes with that technology. And I think what the NHS did at the start of COVID is it mobilized all the technology, but we didn't do enough of the transformation. So you've now got a lot of practices who are trying to just deal with the volume of everything and haven't, through no fault of their own, had enough time to think about how they manage these different channels. And we try and work with as many practices as we can to say, look, if you're going to shift patients into an online channel, you need to dial down one of the other channels. Okay, so dial down your phone access, shift those people that you put on a phone queue into an online channel. And actually you can gather them more information about them up front, it's much better. But I think the thing that the NHS now needs to invest in, if I'm honest, is not so much the technology, but the transformation that goes with it. Let's help practices understand how best to harness this technology and use it going forward. So yes, lots, general practice, the last thing I'll say, general practice is a really, really busy place to be at the moment. We're getting more and more because of the backlog in hospitals coming out to us, all the vaccination. So actually, we need to think more as a system about how we support practices to use technology to really make the system more efficient and sustainable.
Okay, so if it's dialing down one of those areas, it obviously means you're boosting in one. Funding always comes as part of that. I'd like to bring in Mark Thompson on this because you work across the private and the public sector. What are the funding challenges for each of those at the moment, Mark? Can you just set the scene?
Yeah, I guess we've done a lot of work in the last probably 9 months within the region with a bunch of SMEs from industry. And, it always comes back to this funding challenge. We tend to get them involved early on. They have a lot of great ideas, and as soon as we get them engaged with the clinicians, they drive forward innovation so quickly, but then we have to always go back to the funding. And the trouble with the NHS is the cycle is so long. We probably need to find a way to get some of that innovation from the SMEs and the clinicians into a sort of environment where people can get rewarded for the effort they want to put in from an SME, from an industry point of view. Otherwise, they're doing a lot of that work essentially free of charge with no guarantee of where they're going to take that product. It's a huge challenge.
And I can see you nodding along to that. Is this something you've heard with the many people that you're in touch with?
Yeah, definitely. I think a lot of the issue for SMEs, and certainly smaller SMEs, is actually that interaction with the NHS in the first place. It costs a lot of time and money for people to even get on the procurement framework to actually start tendering for these opportunities. And that's something that, we really need to start looking at. We've been lucky enough to actually join in with a digital strategy group that's being run by the North East and North Cumbria Integrated Care System, and starting to look at how we might explore that a little bit more and make opportunities, real market opportunities for the SMEs that we work with. And Dave's been really involved in that as well. And it's a step change that needs to happen. There was a lot of opportunity during COVID, I think, where people were kind of fast-tracked to get these opportunities because of the need. We need to kind of keep all the good stuff that happened there and put in whatever else needs to be in place in terms of governance to ensure that that's done correctly. But we need to keep hold of those kind of opportunities and drive those forward.
I feel like the baton's been passed on there to you, Dave Belshaw. Anything to add to that?
No, I think Mark and Emma have covered most of it. We're also looking at how we actually provide a bridge between SMEs and innovation and investors, because actually that's a bridge that's missing at the moment. So how do we get SMEs in front of investors who will take a long-term view of the health and social care innovation? Because that's also a very, very tricky thing for SMEs to do. And it's almost impossible if you're an innovator with a health. So if you're a GP who's got an idea for a widget that's going to save the world, actually how do you get that prototype built? How do you then get that in front of investors? That's the role of my organisation, but actually even then it's really tricky. So we're also working on that.
Rachel, I was thinking about this faster adoption of all these technologies during the pandemic. Is there any sense that it's shown that procurement can be streamlined safely, efficiently, or do you think it's been proof that we have needed a lot of the red tape that's been there for the past decade?
I mean,
or so?
that's a great question, Charlie, and you're talking to somebody who's probably a bit more maverick than most. So I'm never going to be up for a load of red tape. That being said, it's got to be legal, and I think we've had instances in the last 12 months where certain things have crossed a line. But I'm not going to go into politics personally, or for the purpose of this discussion. But I think that what has happened is we've been in a pandemic, and we have had to move very quickly, both inside and outside of the system. And there's been a lot of goodwill, really, that has supported that. So yes, there's been changes in procurement to allow for it, but a lot of us worked at risk, to help respond to that. We built out the home testing service for COVID-19 for the national solution for the NHS, and we built that out in 8 days. And we went in on a phone call late on a Sunday night with no contract in place. And that, I think, is not unusual in the last 12 to 15 months, because anybody is anybody, and wants to work in healthcare. Of course, you respond in the best way that you can during these circumstances. So I think the rules did relax. I think that they feel like they're tightening back up again at the minute. But I think we should learn some lessons from the last 12 months about what has been achieved by doing things in a different way.
That made me wonder, you're talking about SMEs getting in front of the investors and so on. For you, a point that's been made a number of times on the chat, Dr. Murray Ellender, is that it's great to have a real life GP at the front of this software. Do you think that allowed you to sort of come to the front of the queue? Could there be other great ideas out there, great SMEs in health tech who don't actually necessarily have the medical background that you have or that clinical expertise?
Yeah, I think, look, absolutely. We were very lucky because actually we had a laboratory. I mean, that's what you need. You need a test bed, and we had this test bed of 100,000 patients in practices that we could actually test new ways of working with. And actually, I think that's the challenge. I think if you've got a great idea, I think we've made it easier probably for clinicians now. There's things like the NHS Clinical Entrepreneur Program, which supports those GPs that Dave referenced that have those ideas to help them kind of take them to market. But actually, for others, we definitely need to do more to harness those ideas and make it easier to test them. There's such a barrier. I mean, if you looked at our kind of growth, look how slow it was for 5-6 years, and you've got to have a lot of patients working in the NHS to survive that. And otherwise, a lot of people give up, or they do go overseas. So lots more we could be doing there for sure.
Mark, can I go back to you, because you are interested in the patient and the clinician experience, and I'm just wondering about this movement away from face-to-face appointments in some way. Do you think, even if it's just gathering information to start, do you think it's a good thing for both?
I do, and I mean, we've done a lot of work around patient experience in the Northeast over the last 9 months. So some of the things we've been doing, and some people have different opinions on this, is we've been using a Northeast SME to do some sentiment analysis using AI technology on patient experience, on what people are saying on things like Mumsnet, Dadsnet, Twitter. And, obviously there is a certain opinion about what people write on social media, but it's getting a view of the patient experience before the patient has gone and told anybody about it. So I think when you've got access to digital means of understanding more about the patient, you should use them. It could be looking at social media, it could be access to wearables to monitor certain behaviors when they're at home. Whatever it is, we have an opportunity, just like in every other industry, to know more about the patient, the citizen, the person, without having to see them face to face, and we should use that.
Emma.
Just to add on to that, the great thing about digital technology is making it available to the people that can access it, and leaving room for those people that can't to have more time with the GP. And I think that's a really important point, that whole digital exclusion piece, which is about, if you can access your wearables, your online booking system, your virtual GP appointment, then that's brilliant. But it's also really important to ensure that those people that haven't got the access to digital can still use those services as normal. And I think that's kind of the direction of travel of where we're going here. Just, it's not about getting everybody to use a digital platform, because that will never happen. It's about ensuring that the people that can do and the people that can't have better access.
So claims or concerns about a two-tier health system where you have the internet savvy middle classes who are getting this type of service, and then other people who are less socially mobile getting a slower, more cumbersome process. That's not going to happen, do we think, Rachel?
I guess I'd look at that a slightly different way. I mean, the health service was designed, 70 odd years ago for a very different population. So if we don't start to take advantage of some of the services that we see in everyday life in other industries, then we're going to grind to a bit of a halt anyway. And one of the key motivations really around the Empower the Person program that I ran for the NHS was about reducing footfall into A&E. And by definition, to do that, you've got to start to serve up some of these other solutions in a different way. So I'm not sure I see it quite in that way. Although, I'd like to think I'm digitally savvy, but I was struggling to get into the platform this morning. So that may be a conversation for another day.
Dave, this concern about a two-tier health system, I mean, one other element of that, of course, are the people who work within the healthcare system. I'm sure we all know people who are fantastic carers in social care. They are fantastic with soft skills, but not particularly digitally literate. We don't want to lose them.
No, we don't. I think that there's a lot going on around digital literacy for staff groups. We're about to start a project with Health Education England looking at a self-assessment toolkit, which will then direct staff towards learning resources. So you're absolutely right to say that we've implemented an awful lot of technology, as Mary said, in the last year or so, but we haven't necessarily done the transformation in skills work alongside that. So there's a lot of data at the moment around. We spent a huge amount of money last year introducing video consultations in the North East North Cumbria, and actually there are less video consultations happening at the moment than home visits. So clearly we haven't done the transformation work around that we need to, because it's not being utilised. I also want to just come back to the two-tier point. I believe digital inclusion these days is much more nuanced than it used to be 5-10 years ago. So it's not an age thing anymore. It's not a young person thing anymore. Under 23-year-olds who have smartphones but do not want to use their data on a health appointment. They want to use their data on their social media and contacts or others. That's not an availability thing. It's a desire thing. They're just not going to do it. My mum can't send a text on her 1980s Nokia, but my in-laws are appled up to their eyeballs and editing their own movies. So it's not they're the same age. It's not an age thing anymore. So I think we've got to start thinking in a much more nuanced way around inclusion and thinking about pathways rather than groups. And we need to start thinking about individuals and actually how to use our NHS and social care assets to open up that connectivity world. We've got an awful lot of health and social care assets who do have broadband. How do we make that available to our societies and do much more things around low frequency broadband and all that kind of stuff? That's what's open up inclusive digital healthcare.
Mark, you've thrown something in there. Wow, I'll get shot down now, but is digital exclusion as high as we make out? Look at the vaccination bookings family members can support. I'm going to go to Murray on this one, actually. What do you think? As a GP?
No, well, I was about to put something in the post as well, just to agree with Mark, and I'm happy to get shot down as well. I think I always say often the digital exclusion argument is used as an excuse not to do digital things, which is a real shame. And I'm definitely absolutely an advocate of we should give every patient access, equality of access. But if you shift the digital people into a digital channel, it frees up the other channels so that those people who struggle to get through can get through. So actually, if practices successfully embrace online, the phone lines are free. So those people who always struggled with access historically anyway can get through on the phone. So, or they can walk into the building and be greeted by a receptionist who isn't kind of, tied up doing something else. So I think shift the digital people online. Don't try and shift everyone online. It should be digital first, not digital only.
Okay, right. So if that's the way we're looking, Emma, tell us about the cluster here in the Northeast. Are there, some things on the horizon that we should really know about?
Follow on from Murray's point, actually, we are working with SME in the cluster that actually developed the COVID booking system in Greater Manchester, and their data, in fact, around that kind of whole digital exclusion piece was really surprising. The engagement that they had on that platform across different ages, socioeconomic groups, ethnic groups, was hugely higher than they expected. So one of the points that they made when I spoke to them was they feel, I think going back to Dave's point actually, is it's more about people not wanting to engage rather than maybe not having the access that we first thought. So that's an interesting point to think about as well, that kind of how do we engage people to use these digital tools rather than maybe thinking about the people that don't have them. I don't know, there's lots of different arguments in that whole digital exclusion piece. But yes, talking about the cluster in the region, I mean, there's a lot going on in a similar vein to what Murray's work is doing. So looking at that kind of how do we reduce unnecessary clinician time, addressing that backlog and waiting lists that have been caused by COVID. So there's a lot of that work going on, that kind of digital triage stuff. But then on the other side of it, a huge amount of work also happening in the region of these kind of future focus areas, if you like. So AI, machine learning, virtual reality, all of those kind of things. It's a massive breadth of different work going on, from digital diagnostics all the way through to XR training for surgeons. So, and spanning not just health tech, but life sciences as well. We've really managed to bring that all together. So our focus now, we've done, so my first event for Dynamo was actually this last year, when me and Mark were just actually talking about kicking off the health tech cluster. And over that time, we've engaged with 40 SMEs and various different healthcare organisations in the region, including the wonderful work that the AHSN do. So now I think our focus is more about how we open up those market opportunities by linking in with NHS trusts and the like, and really making sure that the cluster here grows and thrives.
We'll have to wrap up. I just want to add in a couple of the points made by other delegates who are watching this panel at the moment. Jane Kingston is one. She says this is where the advocacy comes in. We're talking about our app today, which helps people link to social care as well as their health services. Anne Fry, digital exclusions layered. Just because someone can book a one-off vaccine appointment doesn't mean they can access their finances, complete job applications. Oh, there's so much. Phil Jackman, of course, is straight in there on AI, and says all of us have a responsibility to address digital inclusion in our customers' employees. I'm sure he'll be talking about that later on as well. And yes, and Kev, very interesting point on digital exclusion. Mark, thank you. So you didn't upset anybody there. You threw something that needed to be said. Rachel, it's great to have you here. Rachel Murphy, Mark Thompson, Dave Belshaw, Emma Whitenstall, and Dr Murray Ellender. Really appreciate it being part of the health tech panel.